Good afternoon, everyone, and welcome to our webinar series. This is Natasha Bonhomme with Genetic Alliance, and today we will be giving an update on the Advisory Committee on Heritable Disorders in Newborns and Children. We are very lucky to have two distinguished presenters. We have Dr. Michelle Lloyd-Perrier, who's Chief of the Genetic Services Branch, Division of Services for Children with Special Health Needs of the Maternal and Child Health Bureau. We also have Dr. Rodney Howell, who's Professor of Pediatrics at the Miller School of Medicine, University of Miami, and is Special Assistant to the Director at the National Institute of Child Health and Human Development at the National Institutes of Health. So now the presentation will begin with Dr. Michelle Lloyd-Perrier.
Good afternoon, everybody. I'm going to be talking first a little bit about newborn screening, and Dr. Howell will be talking, giving the primary presentation on the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children. First, I'm going to give a little bit about newborn screening. The term is often used to refer to two programs that may or may not have ties or linkages with each other. And this is the traditional biochemical screening for heritable conditions, metabolic, endocrine, hematologic conditions, and screening for congenital hearing loss. We're primarily focused on the newborn derived blood spot screening or heel stick screening this morning. So what is newborn screening? There are multiple ways of defining. You can define it as, some people define it as an essential public health program that prevents health consequences through early detection, diagnosis, and treatment. It's seen often as a complex system of testing, evaluation, and treatment that is dependent upon the dedication of persons working within the system. And it's also seen as a public health prevention strategy that, designed properly, it reaches all newborns rapidly and effectively. The public health prevention system includes many participants, family members, primary health care professionals, laboratory personnel, administrative and follow-up personnel, of course the specialty care centers. We have to think about reimbursement. Their policymakers, such as legislators, are part of that system. Manufacturers that manufacture the kits to do the testing, the treatments for the disorders, or the technology that that the tests are performed with. And then there's certainly other interested persons or groups. So first, how did it start? It began in the 1960s when Dr. Guthrie developed a filter paper test for PKU. This test identified newborns with phenylketonuria whose diet could be modified, thus preventing mental retardation. At that time, parents pressed for more testing, and the states began to pass mandatory newborn screening laws. And then at the same time, Dr. Guthrie developed other filter paper tests for other disorders such as congenital hypothyroidism. So many other filter paper tests became available in the 1970s, and besides congenital hypothyroidism, they also included sickle cell anemia. The technology improved, allowing for programs expansion, and this was a simple hole punch, allowing for automated hole punching for the test. And also state legislators began asking programs to become self-supporting, and fees were introduced at this time. In the 1990s, DNA tests were introduced for second-tier testing, and you saw this with sickle cell disease screening and the beginning of cystic fibrosis screening. And this is where you saw the beginning of the introduction of tandem mass spectrometry. And in the late 1990s, the American Academy of Pediatrics formed a newborn screening task force to evaluate newborn screening programs. In 2000, you began to see the introduction of state newborn hearing screening programs, and there was certainly public pressure to expand testing utilizing tandem mass spectrometry. There was also an emphasis on program integration with other public health programs so that you began to see the introduction of health information technology. And there were some privacy concerns that were being raised at this time around the storage and use of residual blood spot. HIPAA was introduced, and that entered into some concerns about data sharing between programs and between the public health and private sector. Also during this time, we had the formation of the committee that we're going to be speaking about today, the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children. Its original name by the department was Advisory Committee on Heritable Disorders and Genetic Diseases in Newborns and Children. It was chartered in 2003. And that name has since changed, dropping in genetic diseases. It was felt to be redundant. At this point also, the American College of Medical Genetics began an evaluation of newborn screening programs. And that was a recommendation that had come out of the American Academy of Pediatrics Newborn Screening Task Force. The likely scenario in which hundreds of conditions could be screened simultaneously and at very low cost and with great accuracy. And two, increasingly effective advocacy efforts and competition from the private market will push for a rapid and significant expansion of the public health newborn screening programs across the country. So a question I think is important that he also raised, does the fact that we can screen for a condition mean that we should screen for it? And much of the discussion about expanded screening has focused on possible risks, such as the possible increase in costs, are available supports for the family and for the public health system in place, or should they be in place before expansion? What's the capacity of states' ability to scale up towards expansion? Does equity matter? Does it matter if one state screens for a set of conditions and another state screens for a completely different set of conditions? Are there any ethical issues? And what's the potential for harm that may come with expansion? Well, Dr. Bailey's work thought that we needed to possibly reframe the issue of benefit. And he made these points, that early identification provides the opportunity to optimize the infant's environment to maximize the potential effective environment on phenotype, if you have, this is with expanded screening. Research has already documented the primacy of the early years and effectiveness of early intervention. So expanded screening for disorders, for even when there may not be what would be considered effective medical treatment, would allow that kind of intervention. Newborn screening provides access to family support at an earlier time and information that can have positive benefits for families and prevent cost to families and society of the diagnostic odyssey they often go through for 2 to 3 years before a diagnosis is made. And for many conditions, newborn screening provides earlier access to an existing program of services that families endorse as both positive and effective, such as the early intervention programs. So he felt that, and his co-authors felt that expanding newborn screening is consistent with research on consumer preferences, on the need for information and the preference for information rather than the keeping of information from them. Also, consumers now are holding professionals accountable and a duty to warn, so that if a screening panel is available and even if you can't treat that disorder, if you're able to screen for it and make a diagnosis early, then professionals, public health and healthcare professionals have obligation to screen. And newborn screening has other benefits to society and science, he pointed out. You can determine the true incidence rate of a condition. You can identify the full range of genotypic and phenotypic expression. It allows for studies of earliest development and the onset of phenotypic features, or you could look at a clinical course of that disorder beginning earlier if you're identifying it earlier. And his work felt that early identification of a group of disorders that may not have treatments, that you could push research and a development agenda on new treatments for these disorders. And then as new treatments become available, expanded newborn screening could provide faster access to families that have affected individuals. So his conclusions were that benefit has been and remains a core consideration for screening decisions. Almost all historical reports reach the same general conclusion: screening should be limited to those conditions for which there is proven benefit. But almost all, 95% of the conditions reviewed by the American College of Medical Genetics expert panel had a treatment that could prevent at least some negative consequences for the child, and all could result in at least some family and societal benefits. In discriminating among the candidate conditions for newborn screening, the question is not whether benefit occurs, he says, but the nature of the benefit, the magnitude of the benefit, and the level of benefit relative to cost and possibility of harm. Historically, benefit is also focused on improved physical health for the infant via medical treatment. Most historical reports focus on this particular benefit, although treatment and benefit are often used interchangeably. Early intervention for those that may not have a medical treatment could prevent mortality in most of the core panel conditions. All of the core panel conditions that the advisory committee is recommending had a nutritional or other medical treatment that could prevent some negative consequences. And screening for all conditions has perceived benefits for family and society. But although reports acknowledge the possibility of these benefits, only two, from the WHO and the National Academy of Sciences, consider these legitimate bases for policy decisions. Most reports consider such benefits for families and society as additive to infant benefits rather than a standalone justification. So that there ends up being no agreed-upon threshold for meaningful benefit. What level or kind of improvement in well-being should be considered as sufficient? How do we weigh direct benefits to the infant in relation to benefits for families or society? And what level of quality of life would form a threshold below which screening would not occur? These issues are complex and, of course, value-laden and very often difficult to quantify. And most reports ignore this question completely, focusing primarily on the possibility of treatment and generally considering medical treatment. Professionals tend to endorse a more conservative stance, insisting on improved health outcomes. Parents and advocacy groups generally take a much broader view of benefit. In fact, many would argue that information about a condition would constitute sufficient benefit regardless of treatment potential. And for many parents, there is no such thing as an untreatable condition. So after I'm finished now, we'll go on to the specifics about the advisory committee and the nomination process for nominating conditions to be put on the newborn screening panel. But I'd also like to hear your thoughts later in our discussion about what your concepts of benefit are.
Great. Thank you so much, Michelle. So Dr. Howell, please go ahead.
I'm going to be specifically discussing the advisory committee that Michelle has already alluded to in her earlier presentation. I won't go into the authorizing legislation. Michelle has already mentioned this somewhat, but the committee was established by Congress under the Children's Health Act of 2000. That happens to be the same act that established the National Children's Study that many of you are aware of. The committee first met in June of 2004, and although the charge for the committee is broad, to date the committee has focused very substantially and almost entirely on newborn screening. And as Michelle mentioned, the committee was reauthorized in 2008 and was renamed with a slightly shorter name. If you look through the charges for the committee, which are substantial, it advises the Secretary on a grant program that's associated with this legislation. Historically, that grant program has not been funded. That recently has been funded. But the core activity of the committee is to provide advice and recommendations to the Secretary of Health and Human Services on the morbidity, on situations that will reduce morbidity and mortality in the area of newborn screening, and also provide information on appropriate universal newborn screening tests. The committee is comprised of a group of folks who have medical, technical, and scientific information, but also they're important members of the public who are voting members of the committee. And interestingly enough, they're representatives from the CDC, the NIH, and HRSA, and as in the new reauthorization from the FDA, who are voting members of the committee. Michelle has already pointed out that there are a few factors that are driving expansion in newborn screening, and I think the folks on the telephone, on the webinar, are aware of the fact that newborn screening is expanding considerably. The ability to do more newborn screening has been technologically driven, not that you have a test and you decide to implement it, but the techniques such as tandem mass spectroscopy have permitted us to add a number of important conditions. Newborn screening is a public health measure, as you know. In all cases, newborn screening is under the aegis of the states themselves. And so there's been considerable variation in newborn screening, and that's one of the reasons that the recent recommendations have aimed to reduce that. I might also point out that the expansion of newborn screening has been driven very, very extensively by the efforts of advocacy groups that have advocated at the state and national level for expansion of newborn screening and support programs in their states. This next slide simply shows a chart showing that in the year 2000, over a third of our states, 35% to be exact, screened for under 5 conditions. And as we moved out until the year 2006, I'll show you a later slide on this, no states were screening for that few. And there was a considerable increase, as you notice along the bottom in 2006, to increasing the number of tests that were done in individual states. The uniform panel recommended by the American College of Medical Genetics that Michelle alluded to recommended that a core panel would be adopted throughout the country, and they would have 29 conditions, 20 of which were detected by mass spectroscopy, 3 hemoglobinopathies, and others that I've listed here. And there were secondary targets, and the secondary targets were conditions that you identified in the course of identifying core conditions. The committee, Secretary's Advisory Committee, spent a great deal of time reviewing this ACMG report that was funded by HRSA. And after looking and studying the report for the better part of a year, the committee unanimously accepted this report and recommended to the Secretary that he work toward implementation of these recommendations on a national basis. The committee has, since its formation nearly 5 years ago, met in 17 sessions. The committee has studied of all the material surrounding newborn screening, but recently, in recent times, the senior medical focus has been on establishing operating principles of the committee and establishing a very formal plan for nominating new conditions and for establishing the evidence review group for rare conditions. And this would provide the committee a mechanism by which the nominations could be recommended. This is a chart that actually comes from the recent report from the March of Dimes, which simply shows, again, in 2005, at the time our committee first started working, you can see that there were still states that were doing fewer than 10, a number that were doing less than 20, and fewer than half the states were more than 21. And as you move up to December 2008, you can see there's been considerable harmonization. It's not complete, but most states are currently screening for those conditions recommended by the colleges. There are small exceptions as you go around, and there are certain areas where we still need to work, but there's been dramatic harmonization with still work to be done. Now, what are the challenges for newborn screening? Michelle has talked about benefit, but they're an enormous expansion of potential targets. There are lots of technologies you could use, and a number of the conditions are rare and very poorly understood. I want to emphasize the fact that there is very little peer-reviewed material published on these rare conditions. Sometimes the number of conditions is extremely uncommon, and so there has not been an opportunity to study them in detail. And incidentally, there are almost no control studies, because when a condition is identified that appears to have a considerable benefit, one is not going to identify a patient or a child and let them go untreated if you know that there's potential benefit. This is the panel recommended by the American College of Medical Genetics, and I show you this because when the college evaluated 84 conditions, there were 23 conditions that really couldn't be considered further because there were no tests available. And obviously, if you don't have a test, you can't add it to the panel. And I think it's fair to say that the committee, the Secretary's Advisory Committee that we're speaking about today, will be focusing fairly heavily in that category of no test available, because there's a rapid development of new tests and new treatments. Now, how are conditions nominated to the Advisory Committee? The committee has decided that the nomination process should provide a broad access to anyone or group, professional, family, advocacy, who would like to nominate a condition. It should have a careful review. It should have a streamlined process, a transparent mechanism, and consistent criteria throughout the nomination process, and a structured evidence review. One of the, I think, remarkable things the committee has done, it has established an evidence review committee that is funded through HRSA by Jim Perrin at Harvard, and that group is doing a structured evidence review of everything that comes before the committee as far as new nominations. This is the first time there has been careful, structured reviews for rare conditions. The three main areas for consideration are listed: condition, treatment, and test. This is the nomination form. It's on our website, and this is the form that a group would complete if nominating a condition. It has an area for the condition, as you can see on the left of your screen. It has descriptions of the test, and there are considerable details about the test, and there are details about the treatment and key references. And this nomination, once completed, goes to HRSA, and HRSA does a brief review. They do not do a professional review. They simply do a review to ensure that the forms are properly filled out and everything, all the blanks are filled in. Then it comes to a small group of the advisory committee that reviews it. And this is an internal working group of professional and families and others that look at it to say, well, you know, is this really a condition that we should submit for evidence review? Is it sufficiently far along? And they may decide and make a recommendation to the committee that it's really not time to send it for an evidence review. But if the advisory committee elects to send it forward for evidence review, it goes for an evidence review and then comes back to the committee. This is the chart that we follow. The nomination form is completed. It has a quick administrative review at HRSA. It comes to the committee, as shown here, and the committee says, it looks like this is clearly premature. We really are clearly are not going to be able to consider this seriously, and it might not go for a review. On the other hand, if it is really far along, it goes to the evidence review. The evidence review committee finishes their work. It comes back to the advisory committee that reconsiders the study, and depending on its recommendations, make a recommendation to the secretary. We'll come back to that. In considering the evidence review that Dr. Perrin is doing, what are some of the problems they're dealing with? The lack of randomized trial, limited information on costs and benefits, access to evidence. A lot of the evidence is not published. Some of the investigator stuff is in the laboratories of the people who cared for these children. Some of the FDA trials for materials that may be still in the approval state at the FDA would not be available for public information, and some of the material might be proprietary if it's in a drug house. But the evidence review follows the nomination form that I've listed: the natural history, the prevalence, the impact, severity, the methods of screening, and sensitivity, specificity, feasibility, and acceptability of the screening. The benefits of the treatments are obviously considered in the evidence review, the potential harms of screening, diagnosis, and treatment, and the cost if that information is available. The committee also has published presented to the committee and is on our website the decision model and also the search methods that are used. And here are the study selections that the evidence review is using. They're including peer-reviewed published literature. They're doing English language only. They are reviewing gray literature that pharmaceutical companies might have or scientists may have as unpublished. They're not reviewing single case reports. They're reviewing consensus statements from groups as guides, but not for formal abstraction. The data abstraction are following standard quality assessment methods that are used by evidence review committee, and they're also analyzing the data in a standard format. They also, importantly and interestingly, are having focus groups of investigators who work in the area and care for these children, but also families, because obviously the impact and the severity of the condition might appear very different if you're an investigator or someone caring for the patient, or if you're a parent who's taking care of the child at home, and they obviously synthesize the data to the committee. The evidence review committee, once they send their material back to the advisory committee, the advisory committee might make has decided at its most recent meeting to have 4 recommendations. One, that the information and and the studies and so forth are so compelling that the committee may recommend adding it to the core panel at this time, and so advise the secretary. The second recommendation may be not to add it at the panel at the current time, but make it very clear that the advisory committee thinks this is a very important situation. There's compelling evidence that the test for screening is working, that the treatment is working, but there's not sufficient data that has been obtained in perhaps a state laboratory or on the treatment to recommend at the current time, but the committee will make specific recommendations to the nominator and say, we would like you to do these things and come back to us. We think this is a good possibility. The third recommendation is to recommend not adding to the panel, but really don't have sufficient evidence to really to know whether it should be. We don't know enough about the condition yet, or we really don't have compelling information, and so you really need to go back to the drawing board and get a lot of information and then come back. And then the final recommendation would be to recommend not adding to the panel, and that's a definite recommendation. In other words, the committee has sufficient information about the test, the treatment, to make a recommendation that it not be added. In other words, this is a recommendation not to add. Now, what has come to the committee to date on these nominations? Fabre and Neiman Pick were nominated to the committee and were deemed not ready for an evidence review. In other words, there were sufficient issues having to do with the condition, the screening test, the treatment, etc., that it was not recommended for an evidence review at the current time. Pompe and severe combined immune deficiency have also been completely reviewed with a formal evidence review. Both of these were recommended not to be added to the panel at the current time. However, both of these conditions were felt to have compelling information about the test, the treatment, but there were certain bits of information that were conveyed to the nominators that the committee would like to see before making a formal recommendation to add. And I might point out, I'm aware of the fact that both of these groups are moving to get the information that the committee felt was worthwhile. Spinal muscular atrophy was recently reviewed, and again, no formal evidence review was recommended. The newborn screening test for this condition is very good. The treatments for this condition are still in the pipeline, so it was recommended that this group come back again when they have their data out of the pipeline for treatment and so forth to look at it. Krabbe disease has been seen by the committee. It has been recommended for formal evidence review and will be discussed at our next advisory committee that's coming up. At our recent meeting in February, we discussed two very important areas that are affecting newborn screening at the current time. The first of which had to do with informed consent, because as we have worked with states and with the NIH and so forth to look at multi-site studies involving newborn screening, informed consent has been a very big issue. And we had a panel moderated by Jeff Botkin who provided an overview of regulation and oversight of children research. We then had Ed Bartlett who talked about regulatory options for multi-center research because that's the key area we need to deal with. And then Alan Fleischman from the March of Dimes talked about, again, informed consent and provided a review of some research efforts that were undertaken in California and Massachusetts using different models for obtaining parental consent and the different outcomes of those. The other area that we've spent a great deal of time on, we've had a subcommittee of the advisory committee, a working group of the advisory committee that has been looking at the storage, retention, and use of dried blood spots. And Dr. Hannon presented the information about what states do and what are the policies that are in place throughout the country as far as retention times of the samples, use of these, and the policies impacting them. And Dr. Botkin again talked about ethical and regulatory considerations. But the dried blood spots are invaluable for developing new tests, etc. It's obvious that there needs to be careful control of these samples, but they are extremely valuable to moving newborn screening ahead. They have been handled in very careful and restrictive ways in the past, and we would look forward to that continuing. But I think one of the areas that the committee clearly will be working on as we move forward is to have a white paper on that subject. Now, Michelle mentioned the fact that Newborn Screening Saves Lives Act of 2008 was passed last year, signed by the President, and it reauthorized the committee. It established grant programs, and actually funds are beginning to flow into HRSA to support those. It expands the role of the advisory committee. It also establishes an interagency coordinating committee of the federal agencies and also creates an internet-based information clearinghouse for information about newborn screening, and those efforts are moving along very well. The bill also requires the Secretary of HHS to ensure the qualities of laboratories involved in newborn screening and also to develop with the CDC a national contingency plan for newborn screening. This is very, very important in the event of national disasters such as has occurred with Katrina when the Louisiana laboratory was wiped out in that storm, and fortunately they were able to promptly develop good liaisons that permitted them to continue. It also specifically gives the NIH authority to develop new technologies in newborn screening, disease treatments, etc., and it also identifies that program as the Hunter Kelly Newborn Screening Research Program. And as I mentioned, the committee will be working on institutional review boards for multi-site studies. and also will be working very hard to make formal recommendations to the Secretary of HHS about the retention and potential use of residual blood spots. Very important in the newborn screening area. So thank you very much. That was the end of my comment.
Great. Thank you very much for that, for both of those presentations. So we have a couple of questions. The first question is, with the increases in newborn screening, are there privacy standards for how genetic information about the child is handled? Is it maintained, and I think that it is the specimen, maintained past its original use for screening? And I think you are starting to touch a little bit on some of those IRB issues, but if you could please speak to that.
The retention of the dried blood spots varies enormously. In some instances, they are retained in perpetuity. In some instances, they are discarded immediately after the test is done and confirmed. And again, states have different regulations and rules about how they're handled. Some states will permit pilot studies. Let's assume you have a new screening test. And you would like to look at whether or not your new test for Krabbe disease, let's just use an example, works in actual practice. Some states and their legal teams will permit you to use anonymized spots, that is, spots that have had all identifying information removed for them, but they might permit you to use 100,000 of those retained spots to test your system to see if it works. And so that you can see if you're getting large numbers of false of positives. And we know this is a rare condition, but you would also be able to see if you could identify that rare patient with this condition. And other states are vary considerably, and I think that one of the things that the committee hopefully will be able to do will be, after a lot of public dialogue, to make some formal recommendations about how these can be used effectively as far as developing tests, testing quality assurance programs in the state laboratories, and at the same time guarantee privacy and confidentiality of the persons involved.
Okay, our next question is, has there been consideration for establishing a process for removing a condition from the panel?
Rod, do you want me to speak to it?
Sure. I'll speak.
The nomination process that's currently in place that Dr. Howe described is for both adding a condition or removing a condition. So anybody or any entity or group of individuals can nominate a condition for consideration of removing it from the panel or adding to the panel. And the committee is going to take up the discussion of one condition that we do not want to remove, but we'd like to recommend the kind of screening test that should be done for it, because some states have dropped it.
One of the situations that Michelle mentions is tyrosinemia, which is currently tyrosinemia type 1, which is currently on the panel, a very serious condition, and the treatment for this condition is extremely effective. And a screening test that was used early, which is measuring blood tyrosine, is very nonspecific because a lot of premature infants have elevated tyrosine, and so states, because of this elevation, it was common. Some states have said, you know, we really can't deal with it. There's just so many false positives. But the proper marker for that is clearly a different compound, succinylacetone. So we'll be considering that. But let me comment about the conditions that are on the ACMG panel, and I think there's a good bit of misinformation about that. The ACMG panel met over a period of well over 2 years, and the nomination form that was used by that group, and I might point out that's been published, is quite similar to the one that's being used by the committee. The committee has modified it in some way. But the committee went through a fairly similar process. It was not as structured as the committee, nor was it as transparent, but they went through, they had experts review it, they reviewed the literature, et cetera, et cetera. So the process was very similar, although not identical, nor was it as spelled out or as transparent. And I think that is one of the issues that has been brought up fairly often.
Great. Our next question is, generally, how long does the process take from submission to decision? And I believe this is about the nomination process.
Michelle, you want to respond to that?
Sure. The process took longer in the beginning. So for those that did apply early in the beginning, the procedures now are pretty well established and on timelines, and it takes from coming in for administrative review to getting to the committee, at least the internal review, the first review of the committee, the small work group review of the committee, takes place within 2 months, and then on to the committee at the next committee meeting, and that may happen on a conference call or a face-to-face meeting. The committee at this point is meeting around 3 or 4 times a year, but generally just 3 times. So it is geared to that advisory committee meeting. Then it moves on right away, either back to the nominator or goes forward to the evidence review committee or work group, and that process is the longest process of the procedure, and that usually takes around 6 months to do an evidence review.
I would think it would be fair to say, Michelle, that I think if a nomination came to the committee today and was seen by the committee and recommended for an evidence review, that could proceed and get an evidence review and back to the committee certainly within a year.
Which is a lot faster than most other evidence review processes are taking.
The longest thing is indeed the evidence review because having focus groups going back to the individual.
I guess we'll go on to our next question. It's a 2-part question. Is there any way to see the reports or the results for the conditions that were mentioned in Dr. Howell's presentation, specifically to the process that Pompe, SCID, Frabbe, and Niemann-Pick disorder went through? And also, could either of you give a little bit more information about what caused the committee to make its decisions regarding Frabbe and Niemann-Pick?
The committee's reviews are on the committee's website, so you can see the final evidence review for Pompe and SCID on the committee's website, and that's easy. If you just type in the committee's initials, ACHDNC, you will into Google. You can get that website easily. And as far as Fabry and Niemann-Pick, they're different reasons, and the committee transcripts and meeting summaries are also on the website, and you can actually look at the committee discussion for those 2 disorders on that website. I can't remember without going to the website, and I don't think I can do that now, when the committee discussion took place, but I'm pretty sure for both of them they took place either in January or October of 2008.
Both of these were 2008 discussions, but fundamentally the issues that have been issues are is there a test that is a highly reliable test, and has that test been carried out in a state laboratory? For example, we would not want to recommend something that has been done in a research laboratory and had not been done on a population basis, because we're a population-based thing. And you obviously have to have, we have not considered any condition that doesn't have a specific medical treatment at this point in time, although we're very interested in expanded version of benefits, shall we say. We can 2 of the recent ones that we've reviewed, Pompe and SCID. Pompe is a condition that we felt very enthusiastic about. It has an FDA-approved therapy, which is impressive. The pilot data that were available for newborn screening had been done in another country using a test with a false positive rate that would not be possible in the U.S. So fundamentally, that group is working on that, and SCID also is very impressive, and again, looking at getting additional data from population-based screen using the TREC assay that's been recommended. But these deliberations are on our website in detail.
Great. A couple of more questions. When a condition is added...
Wait, Natasha, I have the website address.
Okay, thank you.
So it's www.hrsa.gov/Heritable Disorders Committee. And I just was told that the SCID review will be up today, but it is not up at this present time. They were redesigning the committee website, so they haven't replaced that yet.
Okay, thank you very much for that information. Our next question is, when a condition is added to the recommended panel, will the ACMG report be revised and then republished?
The ACMG report will not be revised, nor will it be republished.
The panel comes from the advisory committee and goes to the Federal Secretary of Health and Human Services, and that advisory committee, at the behest of the Secretary, publishes those recommendations.
Great, thank you.
So the advisory committee recommendations will be published and available, but the recommendations from the advisory committee will be the vehicle for recommending to the Secretary, and they will become really a national type recommendation as we go forward.
Okay, thank you. Our next question is, when a new test is added, is there a uniform formal process across the states for the education of all stakeholders? If not, is there work being done to formalize that process?
It seems to me that that's a good place to talk about the regional collaboratives.
Yes, in the anticipation of the possibility of expansion of screening and recognizing the need to provide the expertise to treat these, both diagnose and treat these disorders, HRSA began funding the Regional Genetic and Newborn Screening Services Collaboratives in 2004. They're well established now, and they're throughout the United States, and we divided the country up into 7 regions. The National Coordinating Center is at the American College of Medical Genetics. So educational activities come out of that National Coordinating Center and are disseminated through the regional collaboratives to the states, and the service systems within both the public health and healthcare service systems within those states. The collaboratives and the National Coordinating Center have established, some better than others, but have established relationships with their local healthcare provider communities, both primary care and genetics, to help disseminate that information. And as conditions are added in, to the uniform panel, we've have projects with various professional organizations, but primarily the American College of Medical Genetics, to develop action sheets, or ACT sheets, which are point-of-care information sheets on each newborn screening condition, and tell in a very simple way what the condition is and what the primary care physician should expect to be done, and a simple outline of what the screening algorithm is for that condition and who to contact for more information.
For our next question, this person would like to know about studies where those results are disclosed to parents, presumably after some type of an informed consent.
There are pilot studies that are getting underway. Michelle mentioned Dr. Bailey, who is a leader in this area, and he has done a variety of studies in this area, but he is currently preparing to launch a pilot study in several states for Fragile X. One of the big problems there has been identifying a test that's workable. But Dr. Bailey is currently putting in place, it's not yet started, but he hopes to start it soon, in several large states to screen for Fragile X, obviously using very carefully crafted informed consent for those studies.
And Dr. Randy Hagermans, because it's a husband and wife team, have developed a possible screening test, and they are going to be working with the state of California on pilot testing that screening test.
And Don Bailey is actually using the Hagerman test that they've developed.
Okay, great. Our last question is, will the evidence review committee ever include, and then this is in quotes, benefits to its criteria? So I think if you could explain a little bit more on the different types of benefits that are included in the evidence review committee's process, please.
Actually, the concept of benefit is included, and both in the nomination process and also in the evidence review process. And to get at the question of benefit to families, the evidence review has incorporated focus groups with parents for that particular disorder so that they can assess a parental perspective on harms or benefits for either the treatment or for identifying the condition, but to actually gather that information from those experts, and that recognizing those issues may not have been in published literature, but recognizing that parents are often the expert in that arena.
It's interesting, the ACMG report that we've discussed a great deal today expanded its recommendations for benefit to include much broader benefit to families. That's been sometime a little bit confusing to people because none of the conditions in the ACMG panel were added for that reason. However, the group that was convened by the ACMG felt that benefit should be defined more broadly.
Great, thank you. Michelle, would you mind repeating the website name?
Oh, www.HRSA for Health Resources and Services Administration .gov/Heritable Disorders Committee.
Great.
But you can just plug in those initials I gave you, ACHDNC, and it leads you right there.
On Google, if you type that.
On Google.
For those of us who can never remember the website, just stick it in Google and you'll be there.
Excellent. Thank you very much. I'd like to thank both of our presenters for an excellent presentation. This was very informative, and I know that the community is always interested in seeing, how the processes are going with this advisory committee. The materials will be available online in our archives for this series in a couple of weeks, so please keep a lookout for that. And the recording will also be available online in the upcoming weeks. Thank you to everyone who participated on the line, including sending in questions. And again, thank you to our panelists. And I hope everyone has a very nice afternoon.
Thank you, Natasha.
Thank you, everybody.
Thank you. Have a good